This is QD Clinic, and I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live. Smart, engaging rheumatologists will be checking in on March 2021 for RheumNow.live. You can register now. Today we're going to talk about hemoptysis and lupus. Really, we're going to talk about diffuse alveolar hemorrhage and lupus and a high risk of mortality. I wrote about this a few days ago in RheumNow. There was a nice meta-analysis done on this very rare, very deadly condition, very deadly complication of lupus. Diffuse alveolar hemorrhage can be quite confusing. These patients are lupus patients. They usually look sick. Their numbers are sick. Their x-rays look like like there's a problem going on. And the question is, how are you going to distinguish someone who's hemorrhaging into their alveolar spaces from those who have an infection, from those who have an acute lupus pneumonitis, which is not infectious but will respond to steroids? The difference being the infection needs, the appropriate antibiotic or antifungal or anti-tuberculous drug. The lupus pneumonitis needs high-dose steroids, and those with diffuse alveolar hemorrhage need the kitchen sink, including pulse steroids, to survive. Diffuse alveolar hemorrhage is associated with a 30 to 80% mortality rate. So in this particular analysis of 8 studies and about 250 patients in those 8 studies, they found a mean mortality rate of almost 38%, ranging from, I think, 29 to 62% in that particular analysis. They looked for what were the independent risk factors for death as an outcome, and they found, number one, older age was a significant risk factor. Second, a longer duration of lupus was a risk factor. Current infection. Now, I don't know if that's real or the confusion of the situation, because again, these people, whenever they're admitted with this problem, it's always infection versus that. They get treated for infection, they later get steroids. In the end, you may or may not know, especially if they died. So concurrent infection or suspicion of infection seems to be a risk factor. And then in this analysis, either receiving plasmapheresis or being on mechanical ventilation were risk factors for mortality. Now, the latter two are probably signs of severe disease, more so than those particular interventions, meaning those are the things you give to patients who are in the ICU when you're pulling out all the stops. I guess the point on this case is early recognition and knowing who may be at risk. Again, the elderly, those with more severe disease. In their analysis, they did not show that lupus nephritis or patients with thrombocytopenia or neuropsychiatric lupus or Cytoxan-treated patients were at higher risk. They did not show, but then again, I don't think it was consistently reported, whether disease activity was a risk factor. You might take into account that, longer lupus, a plasmapheresis, mechanical ventilation, they were clearly people who were in trouble. Maybe that equates to disease severity, because that has been suggested in the past. These people present with acute shortness of breath, dyspnea enough to make them hypoxic. And usually when you look at the chest x-ray, you see patchy infiltrates or whiteout in both lungs bilaterally. That's backed up by CT chest films that basically show ground glass opacities in both lungs, meant I think are representative of the blood in the alveoli and fluid within the lung. The interesting thing about these patients is that when they are hypoxic and acutely short of breath, they will also have a quick drop, an abrupt drop in their hemoglobin that will go along with these opacities and worsening of their PO2, so as to suggest that maybe all the blood going into the lungs is going out of the vascular space. I don't know if that's true. But this is a phenomenon that has been seen. Also, it's also been suggested that if you were able to do diffusion lung capacities, an increase or higher than expected in DLCO would also be indicative of blood and hemoglobin within the alveoli that would alter that particular result. Again, high mortality here, early recognition, early intervention is probably the way to save a life. More QD clinics to come.